Good afternoon. We will be starting momentarily.
Yeah.
Good afternoon. Welcome to the Indian Health Service Health Information Technology Modernization Project listening session. We would like to start off in a good way and introduce Jean Sorrell. Jean?
Yes. Thank you for allowing me this opportunity. And we just pray that Grandfather Creator give you thanks for this day, that you allow us to take and have this opportunity to serve our nations, our tribes, our people. Grandfather Creator, we ask that you grant us the knowledge, the tools, and all of the wisdom that it takes to help us to perform our jobs and to protect all of our tribal leaders. Lem lems tupia pesia. Ask you blessings, Grandfather. Lem lems.
Thank you so much, Mr. Sorrell. So as we get started today, we just want to go through and explain a little bit about the platform. We know that a lot of you are already familiar with Zoom. However, what we want to make sure is that you will see if you lose connectivity during the session, you can re-click your join link to re-access the meeting. If you have any technical difficulties, there is the chat bubble down at the bottom of your Zoom screen. You also will have an opportunity once IHS does their presentation is to provide comments. You can either raise your hand, which is at the bottom, and you can unmute and provide those comments. You can also put in your comments at any time into the chat. When you do provide comments, please be sure to introduce yourself and the tribe that you are representing. I will now go ahead and turn it over to Mitch.
Good afternoon, everyone, and good morning for some of you. I appreciate everybody's time today and interest in the health IT modernization for Indian Health Service. My name is Mitchell Thornber. I'm the Chief Information Officer for Indian Health Service, and I'm a citizen of the Muskogee Creek Nation. So again, pleasure to be here with you today virtually, and also exciting times this week as we have vaccines going out to our clinics and our tribal communities. So really excited to see some light at the end of the tunnel of this long COVID struggle that we've been under, and I know many of you are actively working to mitigate that in your community. So again, just really appreciate your time here at this moment to have this discussion and to hear your comments that are extremely valuable to us as we move forward about modernization. And specifically, we're going to ask for feedback around approach that we might take to modernize. But before we jump in, just want to cover the Ihs Vision. Always keep that top of mind as we move forward with these projects that we envision healthy communities and quality healthcare systems through strong partnerships and culturally responsive practices. Next slide, please. And then also just a high level, our IHS strategic goals and objectives to help orient us to the work that we're doing as it relates to the IHS strategic goals and objectives that were published last year. And broadly, that's access, quality, and management and operations. And you know, the electronic health record really impacts every portion of this at some level, whether that's at the facility level or the way we provide care. But certainly we tie this to management and operations goal 3, and specifically where it's stated as goal 3, objective 3.3, to modernize information technology and information systems to support data-driven decisions. So next slide, please. I'm going to give just some brief updates on things that have changed or new developments over the past few months. But I did just want to let you know that we plan to provide about 15 to 20 minutes of updates here in this discussion, and then we're going to open it up to questions. And so we do plan to spend the majority of the time listening to the feedback and comments and hopefully answering any questions you might have to help understand the opportunity in the responses to IHS for this tribal consultation and urban confer listening session. But want to start off with these brief updates. So part of the project all along has been the need to stand up the project management organization or the project management office. And so IHS has partnered with the MITRE Ffrdc, and the Ffrdc is the federally funded Resource and Development Corporation, to support the ongoing governance, tribal stakeholder engagement, and acquisition planning. So this is really working closely with IHS to perform the work that we need to do to manage the project. And so this partnership is really within the scope of those federal functions and helping us stand up an effective and appropriate project management office so that we can be responsive to the stakeholder feedback, we can be responsive to our engagement plans, and have the capabilities to do this work that represents many thousands of hours of labor to do effectively. So the IHS partnership with the MITRE Ffrdc is through the CMS contract for the Ffrdc on modernization. So just wanted to lay that out, and we're going to hear directly from MITRE here in a few minutes before we jump to questions. So really excited to have their partnership. I'm really excited about the level of expertise that they're bringing, both from the federal system, from some tribal experience, but also the private sector regarding modernization of electronic health records and associated health IT infrastructure. And so really excited to partner with them, and hope you'll give them a warm welcome. Also, we've, over the last year, worked on an interoperability pilot. And so that's really to test what we can do to address interoperability, legacy data, as well as being able to share data with the VA, DoD, our tribal partners who may already be on a COTS system, or even other RPMS systems that aren't connected other ways, as well as our private sector partners that we use every day to deliver care in our community. So interoperability is extremely important. It was called out specifically in our FY 2020 funding bill. And so we had to really move forward quickly to address that need in that funding bill. We also have established a strong partnership with the Federal EHR Management Operations Group for the that's really the DoD and VA team, along with the Coast Guard, where they manage their operations for their shared domain under their modernized solution. So just wanted to highlight that partnership, that we are working closely with the VA, DoD on that shared domain, sharing lessons learned, and it's a really great opportunity to hear their firsthand accounts about their experiences so that we can learn from that and leverage that to the benefit of our implementation as well. And then finally, as far as updates, I really want to refresh that the final report and technology roadmap that provides a lot of the baseline documentation and information was provided in the Dear Tribal Leader letter that was published just over a year ago regarding the modernized health IT research project that was sponsored by HHS. And so that was really good work. And we continue to leverage the documentation and knowledge that was gained during that project to inform us as we move forward. I also published the link to the research project. So if anybody needs access to that information, when we share these slides, and maybe we can get those links in the notes there for folks to click on during the meeting, those will provide some excellent reference materials if you don't already have that in your possession. Next slide, please. Just a quick overview of the 2020 funding. I mentioned the interoperability pilot was driven by the 2020 funding. Again, the appropriations provided $8 million at the end of the CR last year, which I think went into effect December 24th. But then we quickly, as that money became available, we quickly moved into COVID-19, and we started to hear opportunities for additional funding. And we were able to get $65 million from the CARES Act of 2020 to accelerate the project based on our FY 2021 projections and requests, which didn't fully meet what we requested. And specifically, we were not allowed to select an EHR. And so, which is fine because we never intended to select an EHR with that in that time frame, but it did restrict the money. So we are cognizant of that and want to make sure we engage both our tribal and our other federal stakeholders, as well as our appropriation stakeholders, to make sure we're meeting those requirements. So we still look forward to the FY 2021 funding to be finalized, which leads me to the next point. Last week, that moved from December 11th to December 18th as a CR. You know, there's been numerous funding updates, so I don't want to get out of sync with you know, this process that's moving quickly in real time as we speak. But we do anticipate, you know, either another CR or an omnibus bill that will you know, fund the agency into FY 2021. I know everybody's watching that. And so unfortunately, the timing of this listening session, we don't have that information yet to share, but we look forward to that. Next slide, please. And I believe I will hand it off to April Kaplan with MITRE.
Thank you, Mesh. I appreciate it. Hi, I'm April Kaplan. I work for MITRE Corporation. And I just wanted to give you, this is a great opportunity for MITRE. We are pleased and excited to embark on this endeavor with IHS and the tribes. I just wanted to give you a little bit of information about the Ffrdc and who we are and what we do. So we are a partner of the federal government. So we work on the same side of the table as the federal government. We are created by the federal government to work in partnership with them. So we sit, like I said, on the same side of the table to work to ensure good, healthy outcomes for folks in all of our communities. And we address, you know, key challenges, you know, certainly the interoperability and patient-centered outcomes is key and critical to the work that we're doing here. We provide innovative and cost-effective solutions that we work in partnership with our sponsors, which IHS is our sponsor here, to really create those positive outcomes. So we work, like I said, in partnership and together to ensure that we have mutually good outcomes for communities that we serve. So we are a nonprofit, and we have brought together some other stakeholders or some other organizations to work in partnership with us who have expertise around IT systems and interoperability, as well as tribal communities. So you'll see on the right that we have a multitude of partners. We have nonprofits and NGOs that work with us and commercial industries that work with us, as well as international partners when we need international partners, all to make up, and public health authorities, all to make up the Health Ffrdc. So let's go to the next slide. So here are some of the key Ffrdc projects and teams that are working on this particular project. This is not all inclusive of all that MITRE and the partners provide, but it is some of the resources that we bring to the table for this project. And certainly we can provide much more extensive information on MITRE as well as the partners at any point in time, you know, during or after this session. But MITRE particularly is bringing acquisition and program management capacity, as this will result in a very significant acquisition and certainly the standing up of the PMO, systems engineering capacity, as well as being the operator of the Ffrdc, who is bringing everybody together at the table. Grant Thornton will be part of this team as well, and they bring operational and organizational transformation capacity and expertise in healthcare. And MITRE brings healthcare expertise to the table as well. Kaufman and Associates, and individuals from each of these agencies are actually on this call at the same time as well and listening to all of the questions and comments that are being shared. They bring extensive expertise in communication strategies and have worked with tribes, organizational transformation capacity as well, and Indian country reach. And Safety Net Operations Solutions is bringing health data and information technology expertise to the table, and also the background and knowledge of working with community and tribal health organizations. And several of the partners here bring some of the same expertise to the table, and we are a strong partnership in working with IHS and all of you to really assure good outcomes for members of tribal communities. And now I'm going to turn it over to Sarah Gilmore, who's leading the project with IHS.
There we go. Thank you, April, and good day to all. I am Sarah Gilmore, and I feel very fortunate to be the project leader for the MITRE team. As April noted, our team brings a diverse set of capabilities to bear to enable the health IT modernization with IHS. And I want to take a moment, if we can go to the next slide, please. I want to take a moment to orient you to some of the experience we see as relevant to this project. We recognize that HIT modernization at IHS is multifaceted. There's a number of components based on our experience in other areas to bring about the successful modernization and achieve the objectives that have been outlined. This is not just an EHR implementation. We are familiar with those, and we will be bringing relevant experience from other EHR implementations that we have performed. However, we know that that alone does not ensure success, and we also want to enable and apply the experience that we've done at other areas to IHS. We know it's not a one-size-fits-all approach, and as I mentioned, it is multifaceted. Well, we look to draw upon our experience and work in partnership. As Mitch said, we're very excited to work in partnership with all of you to meet the objectives. And there are several unique needs that we recognize are present across the Indian health system. And those are the opportunities for us to bring some innovation and apply our experience in new ways to help you solve meet your objectives and overcome the challenges that you've have experienced to date. Our team includes physicians and clinicians, an area director, and we have experience working across the IT and U facilities and communities that are served. Not only do we have the experience across our team there, but we also draw upon experience from physicians and clinicians working in other health systems as well. We've done a lot with health IT, health policy, and health IT for organizations such as CMS and CDC and FDA, as well as working with various to meet health outcomes for various specialized populations and working to improve health outcomes. So we look to bring all that experience to bear here to make sure that, again, the technology is enabling the processes and improving those processes to also improve the health outcomes for the entire community. The other thing I wanted to note is beyond the technology and the health components of it, we also recognize the needs and the patterns from other major IT modernization initiatives. And we also bring some techniques and relevant experience to apply to rapid acquisition. We've also seen new ways of innovative ways of doing acquisition and have helped with acquisition reform. So those are another set of capabilities and experiences we look to bring to bear and apply for the Health IT Modernization Project. And if we can move to the next slide, please. As Mitch mentioned, we are applying our expertise to stand up the program management office and work on governance, engage with our stakeholders, and also performs the acquisition planning. More specifically, the work that we will be performing is divided into 5 task areas. We are first and foremost standing up the program management office to provide the capabilities for managing cost, schedule, and performance of this important initiative. We also we have a focus on governance to enable the decision making at, as the federal authorities allow for the major investment aspects, but also to ensure there is a shared governance model for the important decisions as we move forward with implementation and prioritization in working to make sure that the implementation is successful for all the stakeholders involved. The third area, task area we'll be working is around acquisition and planning. And that really is to ensure that the right products and services are brought to bear at the right time, and the investment, we're working to leverage the budgets and investments appropriately to acquire those goods and services. The fourth area, and actually I'm going to go back on acquisition again. It's there are a lot of different techniques to enable the buying power of the government that we want to make sure again serves the entire community to meet the objectives of the program. In the fourth area, fourth task area around engineering and architecture, that is to enable the specifications, identify the specifications and architecture to help with the selection of the tools and underlying technologies and infrastructure that will really bring the capabilities to bear for the physicians, the end users and beneficiaries of the system, of the Indian health system, which are the patients and those of you in the communities. So we want to enable the process of delivering healthcare and improving those outcomes with the appropriate application of technologies and the planning around that and the infrastructure. Finally, task 5 is around organizational change, stakeholder engagement, communications. We recognize that an effort such as this with the, that is multifaceted, that is multi-year, there are many moving pieces, and it's important to keep everyone informed, to make sure voices are heard and understood and feed the shared governance, and we can work, again, continue to work in partnership with all of you to make this a successful outcome for IHS and for the communities. And we are very passionate about taking the next steps with all of you. So over to you, Mitch.
Thank you, Sarah, and thank you, April, for providing that overview of MITRE. And again, wanted to introduce the MITRE team, and they'll be on board during the listening session, helping support our responses and follow-ups. But I want to go ahead and really bring this full circle and talk about that high-level timeline. Again, this was established in a modernization research project. We continue to leverage that work, both the documentation as well as some of the planning that was moved forward. And really just want to make sure everybody understands that we partner with the MITRE Ffrdc to stand up the initial capacity for the PMO. There will be other acquisitions that spin out of that partnership, both to shore up the PMO and the subsequent activities that are necessary for modernization. So that's an initial procurement. I don't want anybody to think that we've selected an EHR or selected an approach. And again, the goal of this listening session is to solicit feedback specifically around the approaches before we move into the acquisition plan. And so you can see in FY 2021, we do plan to address data governance, interoperability, and that's when we start to execute that acquisition plan, with the plan to late 2022 to early 2023, depending on funding and the nuances that come out of the development of the work that we're doing now, would be the first time we look at modernizing a site. And so really want everybody to orient to that high level timeline. The acquisition plan, or the selection of both an approach and then an acquisition plan to select an EHR, is in front of us. And so that's work that we'll be engaging in with the support of MITRE. And then the deployments, the first cycle of deployments are, FY 2022 at the end to possibly FY 2023, depending on what we select and how we move forward. And so let's go to the next slide, where we show the 4 approaches. And this just to bring this full circle. Again, the Modernization Research Project and the partners that worked on that did a great job of helping to focus the conversation around these 4 approaches, but we're not defined or limited by these approaches. But I think it's a good framework for us to discuss this. And the first one is stabilize RPMS. We know we have to do work to support the RPMS users and patients that will rely on RPMS for the next 7 to 10 years as we complete this project. There will be that need to continue to invest and modernize that to the right extent. And so stabilize RPMS kind of becomes a baseline. So everything that we do has to address the usability of that system during the implementation. So we'll always be doing some aspect of stabilize RPMS, but then how do we move forward? Do we rewrite RPMS? That's option 2. Do we do a selective replacement where we rewrite portions of RPMS, but maybe use a commercial lab system or a commercial ER system or acute care system, some mixing of those 2 modes. And then the full replacement is looking for a suite or solutions that meet our needs across the country, that we can leverage the commercial sector to provide that service. So that's really the high level approaches that we're discussing, and we're asking specifically for feedback around what are your thoughts around this approach? Do you have strong feelings? And we want to solicit that feedback before we make a final decision on that approach, which will then give us the necessary feedback to start the acquisition plan with the right approach in mind. And we are asking for that feedback, but as always, we are very interested in your thoughts and concerns. And so don't feel limited by those. If you have other thoughts and concerns, we're happy to help answer those around modernization. But the decision that's ahead of us for the agency is to review this feedback from our tribal stakeholders, our federal partners, our urban stakeholders and partners to make this decision and get the acquisition plan moving forward, which will then subsequently drive other listening sessions and other engagements. So this is not a one and done request. But it is a necessary first step to get us into the right path so that we can continue this discussion with you in the future. And so with that, I want to go ahead and pause and start the question and answer session. And so Jennifer, is there a process for asking questions? And we'll go ahead and move into that phase.
Fantastic. Thank you, Mitch. So you can either type your question into the chat, or you can unmute. Simply look at the bottom of your Zoom screen and you have the microphone and you can unmute. You can also start your video so we can see who is speaking. Just remember to please introduce yourself and the tribe that you are representing. And we can go ahead and start that now. For those of you who are just on the phone line, you can unmute your phone line and provide your comments as well. So we did have a question earlier for those who may not have seen it. It asked, what does Ffrdc stand for? And it is a federally funded research and development center.
And I see a question in the chat regarding what are we doing to develop a standardized approach for contact tracing. So we do have a group. Let me back up. We did stand up an incident command system across the agency, and many of our federal and urban partners have also set up their own incident command system. So we meet regularly. There is a concept of operations that was developed through the incident command system. And we are looking at leveraging tools that are available, and sometimes that depends on the area or the tribe or the public health authority that is operating the contact tracing program in a region. So we partner with those regions, and so you'll see in the Four Corners area, for example, they're working with multiple states, and in some cases working with multiple systems. And so we do try to standardize that concept of operations, but we do try to embed in those local contact tracing programs that are regional or by area. The facilities often are called upon to do release of information into those contact tracing efforts. And so we support them to do that with documentation and guidance. We've also looked at what platforms are appropriate for a federal information system. And so we're currently working through that with a work group. But we have sites that have deployed the CDC solution TIM2, and they are using that or a combination of that and RPMS to do contact tracing. Contact tracing is something that I think has been highlighted this year. And obviously, as we look to modernization, we will be looking for, what's the appropriate way to do both employee health and then the public health components of contact tracing in this new environment. So great question, and appreciate that question.
Mitch, we do have another question about this timeline here. It says, is the receipt of additional funding contingent on selecting an EHR?
I might say that in reverse. The selection of an EHR is contingent on additional funding. And so in FY 2021, we are looking for an amount that would allow us to move forward, with a successful engagement based on the approach or final decision that the agency renders here, which of course we're talking about, what's the tribal and urban feedback, and also we're soliciting our federal feedback as well around that approach, so that we can move forward with that in FY 2021.
Hi, Mitchell. This is Angel Galvez. I'm the Chief Executive Officer with the Bakersfield American Indian Health Project. There's a lot of talk about RPMS moving into a lookalike EHR system. Many of us are already contracted with EHR vendors to perform our clinical outreach and referral, some grants, and behavioral health services. So I'm just curious, for those UIOs who are contracted with an EHR system, what will be the benefit of dumping an EHR system and rolling into an RPMS system that is functioning very similar to most of the electronic health record systems?
Thank you for that question. Great question. I'm going to touch on a couple of points, and one is, we're looking to design our infrastructure that is more centered around data than it is around a specific EHR, and that's driven by our need and recognition, or our need to accommodate tribes and urban partners that have already modernized, if you will, and have moved either into a partnership that provides their EHR, or they've moved to a commercial system that they support. And so in recognition of that unique aspect of our environment and our ecosystem of data and electronic health record, coordination of care, and all those things that come to bear in that conversation, we're setting up an infrastructure that supports collaboration and interoperability with any Office of the National Coordinator or ONC certified health IT technology. And because we're building our interoperability on standards base, it allows us to move forward with that broad perspective of interoperability. And specifically, we're not going to require or mandate urbans or tribes that have compacted to make any changes in their infrastructure. We're going to meet them where they're at, and we're going to set the project up so that we leverage their investment, that we don't detract from that investment, and we don't force that investment to be readdressed by the tribal or urban entity. So that's our goal. And then as we stand up a federal system to replace RPMS, and I say replace RPMS because regardless of the approach, the outcome will not be what we have today. If we've identified the scope and breadth of what makes a modernized infrastructure, and that has to do with being able to leverage modern infrastructure, so that we're redundant, so that we are easy to use in rural or low broadband scenarios, so that we can leverage modern tools for patient engagement, so that our providers and nurses are able to use a system that aligns with modern workflows and systems. And so, whether it mimics or is a system that they use in other places, we know that we want to be very familiar and have modern capabilities so that a provider doesn't come into our health system and look at the tools we provide and say, well, this doesn't help me be successful. This doesn't help me help my patients. And so with all those things being said, what we're going to end up with will not be a lookalike RPMS system. That is not our goal. And again, our goal is to have those modern tools and bring all of those modern capabilities to bear for the benefit of our patients, our providers, and our care teams, and our healthcare operations. So hopefully I've painted a picture of how we want to approach that. And to bring that full circle with your specific request, my hope would be that you're not forced to readdress your situation and your current leverage use of an electronic health record with the partnership that you described, unless you see a benefit to that and want to move to that. And then obviously we are going to try to build a system that people want to use. We want to build a system that leverages the government's buying power to reduce costs across the country, and not so much the costs to mitigate the costs, but to make it sustainable, so that we can build it into our healthcare operations and have good tools that we can maintain in a rural setting, in our tribal settings, to be effective all the time, and to keep up with those modernizations, going forward. This is a multi-year endeavor, and you want to make sure that not only do you put a system in place, but you've trained people correctly on it. You've built it correctly. We're supporting it correctly, and so that it maintains high functionality and high value throughout the life cycle of the investment. And so all those things being said, we obviously want to be attractive for anyone that wants to use that system. The door is open, that opportunity is there. But it will be because, if folks would need that, if they want to move to that, then they can. If their local partnership makes the most sense, then we want to support that as well. That's part of supporting sovereignty. That's part of being an effective partner in our communities and recognizing that healthcare is delivered locally. And we want to be a good partner and deliver the tools that best help you locally. And so in that role, we would focus on that interoperability. We would focus on what we can do to help your vendor support you through national standards to make sure that if you want to report GIPRA metrics, that you're able to do that regardless of your EHR. If you want to move patient records with a partner that's using our solution and maybe RPMS and other COTS, that you have those tools to be effective. That you can run if you're participating in the diabetes program, that you have access to, regardless of your system, to perform the annual diabetes audit and support the data request for that program. So a long answer, but a really good question. I want to pause and just check with you, sir, to see if that answered your question or if you have any follow-ons. Thank you.
Thank you, Mitchell. It does. I think it sounds like in your comments, what I'm hearing is that RPMS will either complement whatever EHR system you're utilizing, and in the same fashion, RPMS will become more user-friendly for those who are still on a full-scale RPMS EHR. Thank you.
Yeah. Thank you, sir.
So we do have two questions, Mitch. We've got one from Michael Cook. He says, I understand RPMS started with the VA. Is this solely an IHS undertaking or other federal agencies involved?
Yeah, great question. I won't go too far into the history, but there's some documentation that we delivered in the Modernization Research Project to really understand the genesis of RPMS. And actually, we think that the VA started with RPMS from IHS. So IHS started RPMS, and at some point we handed it over to the VA, and they expanded that package. They invested a significant amount of resources, over a couple of decades to build what we now call the modern EHR. But the actual genesis was somewhere in the range of 4 decades ago, and I may be misquoting this, but I believe it started at Chin Lee. And the need to document blood pressures, at a community level. And so really proud of that work, because it shows the forward thinking, the data decision design, decades ago. And so really proud of that genesis and want to make sure we understand that. But want to recognize that the VA is absolutely providing a significant amount of support that the IHS leverages. And specifically, they do a lot of development in the lab, radiology, and pharmacy packages that IHS would have to pick up at a significant expense as compared to what we do today once the VA completely moves away from that code base. That being said, the VA has extended their support contracts for their code base. So they're continuing to do that work. So just like our recognition of option 1 or stabilize RPMS, you can't abandon that solution until you get everybody off of it. They continue to support that. But we would anticipate, we've not heard a date, but we would anticipate that they're going to sunset that support at the end of their project. And that's probably 8 or more years away from now, but it could be a little earlier. We know that they signed a 5-year contract last year, so there's 3.5 years or so left on their support contract. We do anticipate they'll renew that. IHS has an MOU with the VA where we have access to the work or the code that they develop. And so our contractors and our development teams incorporate those changes and review those changes and look at how best to use those for IHS. And then that's how we leverage that work. And then, of course, we have calls and we have lots of partnerships with them where we discussed, in detail some of that work. But that's kind of the support model. And so it's a really good question because you can see that the VA moving away from the RPMS or the Vista code base has a direct implication on our ability to support that code base. And so to that extent, yes, there are other federal agencies involved. And specifically the VA, DOD, and Coast Guard are moving into a kind of a managed domain or a central effort. Broader than that, on our effort, we are looking for partnerships with numerous other federal agencies. That's whether that's HHS itself, but also our other partners with CMS, CDC, ONC specifically. We've done a lot of partnership work with ONC, and they sit in on a lot of our meetings, and we are looking at bringing them further in to those discussions, because we want to make sure that we're guided by the best information coming out of the agency that's helping do some of this work nationwide. So to that extent, that's a very broad answer to other federal agencies involved. Yes. We also mentioned our engagement with the federal EHR committee firm that's running the governance for that shared domain for the VA, DoD, and Coast Guard.
Thank you,
Thank
Mitch. We have a question from Rusty Pickens. It says, "Hi team, apologies for joining late. And if you could clarify if all 4 of these options are still on the table. Looking over the latest Dear Tribal Leader letter, it looked like the agency was pursuing option 4 exclusively. And if so, do we have any sort of estimate for the anticipated funding / budget needed to accomplish that option?"
Yeah, great question, Mr. Pickens. Thank you for that. Absolutely, all 4 options are on the table, and we've actually alluded that, you know, option 1 is kind of a prerequisite. I don't think we can get away from some level of stabilization work in conjunction with an approach to modernize the infrastructure. And our intent with the Dear Tribal Leader letter was to be plain and transparent that we think option 4 makes a lot of sense, but that's our opinion. And so we wanted to be clear about that, so that if someone felt strongly, they would know which way we are leaning. But that decision has not been made. All options are on the table. And again, option 1 is a little bit of a tag along to any of the other 3. We simply can't abandon the RPMS infrastructure, but we certainly want to have smart conversations, you know, about how do we do that effectively and how do we move forward with all due haste, but at the same time not abandon again our millions of patients and thousands of healthcare providers that will need to use that system for several years. And so that's going to be a balance and a discussion, and hopefully one we continue to have as a community, and engaging all of our ITU stakeholders to make sure that we strike that right balance, because we don't necessarily know what that is. And depending on the funding levels, you know, we're asking for an amount that we would hope allow us to move forward with modernizing the entire infrastructure. But we're still working with our tribal and federal and urban stakeholders on what that should look like. And we are looking at what our funding stakeholders think that they can support. So that's very much an ongoing discussion. We have some ballpark figures, but until we move forward with a true acquisition plan and we nail down some of the decisions about the infrastructure, we won't know what that full cost is. Additionally, you know, purchasing the solution, the licensing, if you will, purchasing or leasing the capacity to host the data and host the solutions and build the actual servers and things that go behind the scenes to make a system live, you know, that's just a portion of the cost. There's also the cost to implement, there's the cost to go live, there's the cost to train, there's the cost to backfill. There's also the cost to remediate. And one of our lessons learned from the VA was that the cost to remediate each site that was going live was fairly significant. And so they had to up their requests specifically to Congress, I believe in 2018, to address remediation. And so we are cognizant and recognizing that remediation costs will be a site-by-site cost that has to be looked at fairly close to go live. So, you know, I can't take a site that's going to upgrade in 7 years and tell them all the things that they have to upgrade at their site, you know, whether that's radiology equipment, lab equipment, vital signs monitors, infusion pumps, all these things that in a modern EHR become part of the system, if you will. All that remediation, you know, server rooms at the local sites, wiring, access to, you know, desktops, laptops, portable computing to support the patient care environment. all those things have to be done fairly near the implementation. And so we can develop the framework, but we'll have to feed it fairly close to that implementation to understand those costs. So some of those costs will be site by site. Some of them we will be able to plan after we make a selection, and that'll be this year. And so we'll better have a better understanding, and we'll be calling for more specific funding levels as the program progresses. And as always, we want to address the full needs of the ITU system, recognizing that many of our partners have already invested in technology and in modernization. And so that's very much part of the conversation as well. But unfortunately, don't have hard and fast answers for that question, just how we're approaching it. But great question. Thank you for that, sir.
So Rusty says, agreed. Whatever we choose to do will certainly be a multi-year effort, and we'll need to keep RPMS healthy throughout that time frame for sure. Thank you for the clarification.
Yeah.
A question from Michael Cook. What is the timeline? How much life is left with the current system?
Yeah, that's a great question. So as we've talked about, we anticipate 7 to 10 years to do a full modernization, and it's multifactorial. There may be sites that aren't ready before then. We have challenges associated with the digital divide, associated with, as I talked about before, with remediation activity at the site level. And it's an investment in training and organizational bandwidth to address this really massive project. Implementing an EHR is not really a pure IT function. This is a project that really engages everyone in a facility at an area level, at a system level. And the amount of organizational change management that goes into that, it really starts to look a lot less like a technology project than one might imagine. And so we know the technology is mature. We know that there are opportunities to be successful. There's multiple paths forward for success from a technology standpoint. The multi-year approach is to address both funding levels, because once we build a system and we know what it takes, the idea is on a long-term multi-year project that we titrate our progression based on funding levels. And so if there's variability in our funding levels, which at this point we have to assume could exist, because we've not been given a bolus of funding like the VA or the DoD to just go out and implement. So we're mitigating that risk by identifying the system we need, building that framework, and then how fast we move forward might move up the years, up or down. And so if we get a lot of funding, it could shrink the timeline. If we don't get as much as we would like every year, that might extend the timeline. And so that's a risk we have to address. And that's the way at a high level that we're looking at that because of our funding uncertainty. And so to your question, we anticipate, supporting RPMS in that 7 to 10 year window. We want to be, we talked earlier about, really approaching that in a good way that makes sense to the most stakeholders. There may be opportunities to accelerate acute care. And if we're not having to support acute care in RPMS, that has a significant impact on the level of effort to support it in the out years. So you might see a strategic or a plan or a strategy proposed to accelerate the adoption at the 24 federal hospitals and the 24 or 25 tribal hospitals that might be using RPMS, because it has a good long-term effect on that strategy. As far as how much time is left in the system, we're not abandoning that code base. Last year, I know we released 105 releases and updates to RPMS. This year, we've released a similar amount. And most significantly, we have released the 2015 certified edition to improve quality and outcomes for our patients that use that system or need that system. And so we will continue to, mark a path and a trajectory that keeps the needle moving on healthcare outcomes for our patients. And so I don't want to say we are pursuing certification for meaningful use reimbursement or some of those things, because financially it may not make sense. We're pursuing those because we want to have a viable system. We want to participate in quality initiatives across the country, and we want our tribal communities to have, you know, a tool that can meet those quality outcome requirements. So it's more than just pursuing certification or compliance. It's about moving with industry standards and moving with opportunities to improve outcomes, leveraging technology. So I feel like we will keep RPMS viable until we can get everybody off of it. We're not going to let that ship sink while we have patients and providers and care teams relying on it. And so that's how I would say how much life is left in it. We're going to keep moving and investing to make that a viable and keep that a viable solution and potentially improve it from where it's at today. But with a strong eye towards the generational benefit of modernizing that infrastructure, getting off that, code base that we are the only ones that maintain. You know, as I mentioned before, there's less than 50 hospitals in the country that use RPMS. And so when you start to look at the market spread, you know, we've really got to question, do we want to be in that software development business? And that's why we're asking for feedback around these approaches, because that will significantly impact how we move forward and what that funding level will be and what the stabilization plan will need to entail. So great question. Thank you.
Thank you, Mitch. I don't see any other questions. So as a reminder, you can go ahead and unmute to ask your questions and also start your video camera. Those two icons are at the bottom left of your Zoom screen, or you can put it into the chat. We do have another question from Michael Cook. Has a modernization advisory committee been established, reference in project document 2019?
I want to double check the reference, but if that's the modernization research project, yes, there was a modernization advisory committee that was established both with tribal stakeholders. So we did have participation from a member from DSTAC, or the Direct Service Tribal Advisory Committee, as well as TSGAC, NCUI, and ISAC on that advisory committee. And then we also had several members from the private sector and other agencies, including ONC, on that advisory council that helped with the discussions around the modernization research project. As we are moving out of the research project and into the actual modernization project or program for IHS, we are in active discussions about how to re-roll that modernization advisory committee. We are in active discussions around how to stand up that governance and making sure that we have broad representation. And again, looking to those same partners that we established, not only reaching out broadly through listening sessions and broadly to tribes directly and our urban stakeholders and also our federal stakeholders, but we are leveraging those established partners and pathways through the modernization research project learning to make sure that we're engaging ISAC, to make sure we're engaging DSTAC, TSGAC, and NCUI to get that feedback about how we should structure. And so, yes, in the scope of that project, the Modernization Advisory Committee was established, but that has since sunset. But we are looking at that reactivating a similar model in the actual modernization project. Thank you.
So we do have another question from Ramona Benelli. My apologies, but you might have already mentioned it, but can you share a little bit about any plans to connect IHS EHRs to local state HIEs? I think this is crucial to improve care coordination for IHS patients who are referred to a non-IHS facility.
Yeah, really great question, Ms. Benali. So when we talked about the interoperability pilot project, this is really an area of focus to make sure that, again, that we don't devalue the investments that our tribal leaders and urban leaders across the country have already made to modernize their infrastructure. And so we don't want to detract from that. And then you point out all the you know, all the requirements and benefits of having an interoperable healthcare system. You know, we refer these patients out. We sometimes pay for that care, and we certainly want to know what happened to them when they were out getting it. But we also know that it improves care coordination, that less people fall through the gaps, that you have better community coordination of resources that can be used to improve outcomes, you know, simply from deduplicating care to getting care in the right way, but also to know when your primary care patients are discharged. And so we know that those state and regional HIEs provide a lot of value. We are in the pilot project creating and testing our interoperability with the National eHealth Exchange that already has federal partners on it. So that includes the VA DoD, as well as many of our tribal stakeholders are already using that, whether it's directly or through their vendor-specific connectivity options. So eHealth Exchange has a connector to Commonwealth, for example, and also MyCare Anywhere for many of the Epic people. And so we're very much looking at that pilot to learn, and that's our evidence-based or industry standard certified way to approach interoperability. That being said, you know, any system we build, we know that we're going to have to connect to multiple HIEs. There's no one and done solution to connectivity. And we know that the care is local, and, you know, any boundary that someone draws around where they refer people to, there's exceptions. There's always somebody going outside that nice clean circle of here's where we send our patients. And so, you know, we're trying to build the capacity to aggressively connect to regional and state HIEs. And we anticipate that if we, you know, have our solutions lined up, we'll still have hundreds of connections to HIEs that have to be managed in a way that's respectful of data sovereignty, that protects patient privacy, but also enables that coordination of care and community response to our health, the health of our people. So thank you for that question. And that would include non-IHS facilities, community partners, as well as other federal partners.
Thank you, Mitch. Just a reminder, you can go ahead and unmute and share your video to ask any questions, or you can type it into the chat. I don't see any other questions. Again, you can put them into the chat, or you can unmute and start your video to ask any questions.
While we're waiting for questions to come in, just, you know, want to reiterate that I really appreciate the broad questions and really the engagement. This is really good. I think a really good discussion. So if anybody has anything, please feel free. This is a good time to have this discussion. And again, while we're looking at the next decision point for IHS, that we want to make sure that we've incorporated tribal and urban feedback, is this approach. You know, very open to answering those questions that help you understand what we're trying to accomplish, so that you can have a robust, you know, response back to the IHS. And just as a reminder, the Dear Tribal Leader letter identifies January 24th is when we'd like to have those responses back, so that we can start to incorporate them and move forward. So I see a question in chat. Has a cost-benefit analysis of these 4 options been published yet? No. We've done some cost modeling, but the options require some selectivity. And so you got to do some design work to move forward with those cost-benefit options. We are looking at what are the cost drivers and what are the pros and cons of each. And that's what we would want to publish when we render a decision, is how that decision making was accomplished, what were the factors, what was the tribal and urban feedback, and how did we address it. but you know, there's a huge cost discrepancy between even options within 4. You know, so you know, just to identify the costing options in option 4 are fairly significant, and a lot of them have to do with how we support and make a sustainable solution available for all of our stakeholders, and that will come in to play, as well as a cost benefit analysis, but also that sustainability plan. You know, can you recruit the staff in rural parts of the country to support that level of technology debt that we might establish through these decisions? Thank you for that question, Ms. Wilson.
Thank you. Just a reminder, you can unmute. You have the mute button at the bottom left corner of your Zoom screen and start your video, or you can enter any questions into the chat.
Yep, and I just want to recognize the comment from Ms. Benali. Appreciated her question earlier. And you know, health information exchange, I really believe is an investment in our future capabilities. I've personally been involved in HIEs, specifically in Oklahoma, for the last decade, and really feel like you know, the investments in the future here lay the groundwork for you know, really improving health outcomes. By knowing what happens, we can know what needs to happen, and we can measure it at a community level. And you know, having that local control and visibility into outcomes and coordination of care is so important. So really appreciate that you're already involved in HIEs, and hope to really accelerate that conversation nationwide in Indian country for us. So thank you.
Thank you. Just another reminder, you can put questions into chat, or you can go ahead and unmute. It's in the bottom left-hand corner of the microphone if you have any questions or comments you'd like to provide. So we do have a quick question. Will the modernization be easy for doctors, nurses, and any employees to convert to?
That's a trick question, I think. You know, we are focused on usability. You know, as we talked about, we want you know, we want to be able to recruit and retain, you know, high quality providers in our communities, and we want to give them tools that they expect to have, and possibly have either trained on or familiar with, because they've either trained on them or used them other places, et cetera. But it's really ease of use. And obviously for folks coming from RPMS into something else, we also want to bridge that gap. And so we, you know, plan to have, you know, specific paths to make sure that the training and the change management aspects of the project address those transitions. And again, ultimately, we want to improve usability. So we don't want to go from a system that's easier to use to one that's harder to use. And we think we can accomplish that. That being said, all change is hard. We know from the Modernization Research Project that 96% of respondents to a survey that I think had, I think about 1,700 responses when we measured it, 96%, you know, kind of agreed that now's the time to make a change. So we know that there is interest and a basic understanding of the need to change. But we also know that when that change is in your own backyard, that it's not easy. And so we do plan to address that as part of the project. And if we could go back to the slides on the 5 tasks, just real quick for emphasis here. That task 5, organizational change, that's really what we're talking about. We have a whole task to do the research, to do the planning, to do the execution required to support the facilities through this change that, again, will affect everybody at the facility. It'll affect everybody that uses the EHR directly, but indirectly it'll affect every process at a care facility, because the EHR, the electronic health record, and the associated health information technology infrastructure are really the operating system and environment that we provide care in. There's not really a way to perform the same level of care on paper or without the age of or without the advantage or the capabilities for interoperability or to share data. And so we know how important this is, and we know that this has to be managed the right way. What I can say at this point is we've recognized the importance of this, and it's its own task to make sure that that planning and documentation and support is there once we start implementation. Thank you for that question.
And perhaps you could cover the Dear Tribal Leader letter one more time in the due date and what you're asking for by the 24th.
Yeah, no, yeah, happy to do that. Thank you. So the Dear Tribal Leader letter is requesting tribal consultation and urban confer and responses by January 24th is when we'd like to have those back. We've scheduled 2 listening sessions, the one today, December 17th, and we also have January 14th scheduled as well. And so those are both out in the Dear Tribal Leader letter. You can attend both, one or the other. We'll also, you know, be having this discussion with a lot of folks, whether it's the area level people, whether it's the technology specific folks. And so we intend to do a lot of discussion about this to cover, again, our tribal, urban, and federal stakeholders. And I don't want to forget our federal stakeholders. I know several are on the call today as well. And so what we're soliciting is help and understanding to make the decision about the approach. So again, the Modernization Research Project provided some really valuable research, knowledge, and guidance around how we might approach a modernization project. And specifically, the 4 approaches were to stabilize RPMS, renew RPMS, which means to rewrite it, to rewrite the code, selective replacement, which is really rewriting the code and then selectively augmenting with commercial systems. And then 4 is a full replacement with a commercial system that covers the range and suite of needs of the ITUs across the stakeholder group. That being said, we're not limited to those 4 approaches. I may not have said that earlier, so I want to make sure I say that now. You know, this is recommendations and a guide to help us think about this and to spark this discussion, but we're not limited by these approaches. If there's a unique approach somebody identifies outside of this, typically they fall into one of these broad approaches with some caveats. But I did want to point out that option 1, or stabilize RPMS, is really something that we view as a prerequisite, recognizing that we have thousands of providers and care team personnel, staff, and team members using RPMS across the country, with millions of patients relying on that system to be maintained. And so we don't plan to drop the support for that. And we view option 1 as sort of a prerequisite and a part of the other approaches. But we know that how we stabilize, the timeline, those all depend on that mix of approaches.
Thank you, Mitch. We do have a few more questions that have come in. In addition to organizational change and training, data migration to an upgrade or a new platform is almost devilish. Have we looked into industry practices to make this as smooth as possible?
I'm just oriented to the chat. Thank you. Thank you for that question again, Ms. Wilson. Great question. We're absolutely looking not only at our federal partners and their best practices, and we mentioned a few that we've gleaned from the VA DoD effort. We're also looking at industry standard approaches to how we modernize. And so we are not trying to reinvent the wheel there. We are looking at industry partners and research from Gartner, for example, for how to manage that life cycle, and using, you know, industry standard project management techniques, and also leveraging the knowledge that exists within IHS about stakeholder engagement with our tribal communities. So we're hoping to bring a lot of that to bear in this project. Because this is an extremely tough project. We anticipate this is, hundreds of thousands of man hours, millions of man hours that will ultimately go into this project, as well as involve, tens of thousands of people across the country. So it's absolutely a huge challenge. And we know that even in the private sector, this can be a struggle to execute these projects. And so we're absolutely trying to learn from the industry, reuse what has been proven to work in the industry. We're talking with our, this is a good opportunity to mention that, we actually have tribal leaders and urban leaders that have modernized their infrastructure. They have firsthand knowledge about how to do this in our environment. And so we absolutely want to leverage that experience as well. And I think that's a strength because we have those leaders that have moved the needle and progressed. We can leverage their knowledge as well. And I think that's a real strength for our communities because, again, there are people across the country that have done this in our tribal communities. And we're certainly going to learn from that as well.
So another question is, in concert with the RPMS replacement, what will be IHS's approach to deploying an integrated data fabric, data integration and governance to maximize the value of this investment?
Yeah, so when we talk about the data and the investment in RPMS, that's where we talk about in the future, we want to look at the interoperability pilot, for example, as not only a method for us to create a clinical data repository at a national level to help with data and data sovereignty, meaning a tribal stakeholder or community wants to engage in a specific project, do we have the data and the mechanisms to pull the data to support their data requests? And we want to answer yes to that. So we want to build that centralized, perspective of data, and either centralized or federated. But we want to make sure that without custom programming, without a heavy lift, we can be agile and flexible in the way that we deliver data back to our tribal communities or through IHS to other stakeholders to support the requests coming from those tribal communities. And that might take the form of GIPRA, that might take the form of individual quality metrics, specific grant opportunities, programs from other agencies. All of those things now require data, and we know that needs to be a place where we're agile. Additionally, we know that beyond the EHR that we all use, or use separately, I should say, the data is the real value. The patient data and moving patient data at the point of care to benefit providers and to benefit the patient requires interoperability and coordination. And so, we're really looking at data being at the center of our model, and the electronic health record that we all use separately, because they can be different, is on the outside of that model and is actually the perishable component of the model. Meaning I'm less worried about if IHS switches EHRs in the future because my data has been stabilized, lifted out of a legacy system and put into modern standards that now exist that we think will persist the data for generations into the future. And it's more complex than, C32 exports, but it's not as complex as having to copy everybody's EHR. And so we hope to strike that balance. But again, we're putting data at the center of the model. The EHRs, because there's multiple of them at this point, exist on the edge of that model. And again, the data is what persists, with the EHRs for various stakeholders changing over time and out of sync with each other. But the data is where we're going to drive that value. Thank you for that question. I hope that answers it.
Thanks, Mitch. Another question we have is this project being funded by the $95 million from the CARES Act that remained at HQ to manage telehealth at the national level?
Thank you for that question. No. So we're not using the $95 million for this project. There are some logical crossovers, but the $95 million from the CARES Act specifically for telehealth is not part of this project.
We have another question that says, currently there is very limited interoperability between RPMS, NDW, and COPS EHRs. As part of the RPMS stabilization, can we also ensure that there are allocated resources to facilitate validation of reports and interfaces with COPS EHRs and use by ITUs in a more timely manner? This will ensure a more accurate picture of the data collected regarding the health status of our AIAN patients. This is a huge concern that many of us have that can't wait 10 years to fix.
Yeah, absolutely. You know, as we talk about stabilization, this is one of the areas where we really have to do better quickly. And we recognize the need to invest in interoperability with RPMS. And so the pilot actually addresses both RPMS and the future state in regards to interoperability. So it becomes the bridge, you know, for our project moving forward, but it also recognizes the immediate need to invest more heavily in interoperability, data exchanges, the national data warehouse, and the capabilities to support COTS at that level. And you know, as an example of that, you know, as we made changes, one, we delivered the certified, the 2015 certified edition of RPMS, and then our sites that are able to implement that are able to use our aggregator to report electronically to the CDC on a daily basis their vaccinations that are coming out this week. So this is really exciting news story. And so leveraging that, we were also able to onboard not only federal sites using RPMS, but we've also been able to onboard COTS. And that was a specific focus, and lots of learning happened there. So there's, you know, really appreciate our partners that help us work through that. But it's recognizing that, if you will, the genie is out of the bottle. We're in a post RPMS only world, and all of our plans going forward recognize the need to support commercial off-the-shelf software and multiple vendors to make sure that we're supporting tribal sovereignty, to make sure that we're enhancing the outcomes and meeting the mission of IHS through that activity. So it's a little broad. Hopefully that example about the vaccines really puts a point on it. But it's a broad statement to say that yes, we realize we're going to be supporting more than RPMS when it comes to data. Thank you.
We do have another question about, is it possible an area could ask for financial support to adopt Epic area-wide?
So, you know, there is, you know, an opportunity for people to request regional installations, but you can quickly look at the scalability and the costs, and you'll see that the level of effort, or we believe the level of effort to consolidate to an area level is probably the same level to go at a higher level and maximize your return on investment, or your scalability and cost per user, drive it down. But you know, we're not limited at this point into how we're approaching it, and we're open to what those requests and recommendations would be, so that we can either respond to them or adopt them into our knowledge and try to incorporate them going forward.
Thank you, Mitch. We've got about 5 more minutes left. If there's any additional questions that you have, you can either put them into the chat, or you can unmute yourself at the bottom left of your Zoom screen. We'll give you a few more minutes to see if you have any additional questions before we close out. I don't see any additional questions. Mitch, do you want to, before we go to the closing pair, did you want to make any additional closing comments?
Thank you for that. You know, just really want to thank everybody for their engagement. We'll continue this conversation. We wanted to make sure that we created this opportunity and met the requirements for tribal consultation and urban confer. But we really look forward to engaging you in every venue, and really want to make sure that we're engaging our stakeholders, that we're listening to the concerns and also the recommendations and challenges, so that we can make the strongest effort possible to really have a long-term impact on the way we use technology to improve outcomes for our tribal community. So I appreciate your partnership in that. I appreciate the work that you're doing every day to do that. And I hope that working together, we can make some real advancements in the way all of us use technology, again, to improve those outcomes, share data, and provide patient care in a coordinated way between our communities and in our communities. So just want to leave you with that, and thank you. I hope you and your families are staying safe. While we do have the vaccine, it's very exciting that that's being distributed now to our frontline workers, as well as some of our elders and distributions at the community level. Really want to just say, please keep your guard up, stay safe, protect your family. Remember to watch your distance, wear a mask and wash your hands. Those are the things that we can do to protect ourselves and our elders and our valuable community members. So with that, I will turn it over to Ms. Sorrell for a closing prayer. Thank you all.
Thank you, Mitch. I appreciate the opportunity and the acknowledgement that Indian Health Service has provided today in remembering to open in a good way and to also close. So with that, I would just like to say thank you, everybody, for participating. Thank you for the good work that we all done, that we remember that what was provided today was provided with the best intentions, and that we always want to keep in the forefront the importance of protecting our community, the quality healthcare outcomes that we're all looking for. We pray, as Mitch has reiterated, that we are able to look forward to a time when we are able to overcome the COVID pandemic that faces our communities in such a strong way right now. So with that, I'm just thankful and grateful and look forward to a happy holiday season and wish that for all of you.